Chapter 31, Environmental Emergencies. So in this chapter, we're going to talk about the effects of hypothermia on the body, how to assess and care for hypothermia. We're going to talk about more localized cold injuries and care for local cold injuries. We'll talk about the effects of exposure to heat and how to care for patients with heat stroke and heat exhaustion. We'll talk about other environmental type emergencies, including water-related emergencies and bite and sting-related emergencies. So first, exposure to cold. So these are the ways that the body loses heat. Conduction, where your body is in contact with some colder material, water or snow. Convection, where wind or air moves across the body, transporting your heat away. You lose some heat due to radiation, as all warm bodies radiate energy out. Evaporation, when you have moisture on your skin, like when you're sweating, that evaporates and cools your skin. And then respiration, as you breathe in and out, that air is warmed inside your lungs, and then as you breathe that warmed air out, you lose that heat. So when we talk about generalized hypothermia, the progression generally goes some exposure to cold, which reduces your body heat. The body is then unable to maintain core temperature if exposed long enough. When your total core temperature goes down low enough, this can lead to death. There are some predisposing factors for hypothermia. Any injuries make it harder for you to warm yourself. So patients, for example, in car accidents, etc., need to be kept warm, especially in winter or colder months. Any chronic illnesses also reduce your ability to respond to cold. And in general, geriatric patients are less able to keep themselves warm, and pediatric patients, while they have a good metabolism, are smaller, and their ratio of their body surface area to mass is greater, and so they lose heat faster. It's not always clear whether a patient is suffering from hypothermia or some other associated illness or disease process, and whether or not their symptoms they're presenting are due to the hypothermia or due to other things, such as alcohol ingestion, some other underlying illness, possibly strokes, seizures, overdoses or poisonings, and major traumas. All these things can contribute to hypothermia. So a large fraction of hypothermia cases are complicated by alcohol. As these patients are, when they're overdosed on alcohol, can make poor decisions and wind up in places where they shouldn't be. In general, hypothermia deaths are more prevalent in males rather than females. The rate's about twice as high per year. And in general, hypothermia deaths cause more, or hypothermia and cold injuries in general cause more deaths than heat-related injuries. We have had a few local hypothermia cases here in Moscow. These are newspaper clippings here. The most recent one out by Troy. About 6 years ago, we had a UI student leave a party intoxicated and got hypothermic and eventually died. So assessing a hypothermic patient. Initially, they're going to be just shivering. It's your natural response to getting cold. Shivering generates some heat. When you get down to around 94, 95 in your core temperature, you stop shivering. The patients will complain of numbness in their extremities. They may have a stiff or rigid posture, maybe drowsy, rapid breathing, rapid pulse, ataxia, that loss of motor coordination, seen a few times. Possible joint muscle stiffness. Later stages, they'll be completely unconscious, and their core skin temperatures will feel cool or cold. So treating these patients, we can, for the more mild hypothermic patient, let them passively rewarm. So in this case, we would remove any wet or cold, wet clothing, and cover the patient with warm blankets, or at least blankets, and let them kind of shiver and rewarm themselves. For more severe cases, we need to apply an external heat source, and that's active rewarming. So we apply heat packs, and the best place to do that is centrally. So those heat packs need to go on the chest, neck, armpits, or groin. And the idea there is that we don't want to partially rewarm extremities, limbs, and then have that cool blood flow back into the central core. So we want to rewarm the core first and let that heat kind of radiate from the middle out. The devices we have to do this on the ambulance, we have blankets, obviously. We have some ready heat blankets. Those are the iron powder style blankets, and so they react with air once they get opened up. They do take some time to activate, so you want to activate those before you think you'll need them. They can take 10 to 15 minutes to heat up. We do also have chemical heat packs, and those heat up within a matter of seconds, but we have a limited number of those. In cases of extreme hypothermia, so somebody's buried in the snow or cold water drownings, these kind of things, they may appear dead from the external, so heart rate can slow to 10 beats a minute. They'll be very cold to the touch. If there is no pulse, we'll do our standard CPR with AED. If they do have a pulse, then we'll care for them by breathing as is necessary, protecting their airway. And these patients need to be actively rewarmed, with the idea being you're not dead until you're warm and dead. There have been some patients that have survived fairly long submersions in cold water, especially, and have been recovered. For more localized cold injuries, so your frost nips and frost bites, we're generally going to allow the hospital to treat those or treat those at home. So these are going to affect the parts of your body that stick out the furthest, so ears, nose, face, hands, feet. And what we're talking about is those tissues freezing solid, at least in the case of frostbite. And so for these, we're going to, in general, just cover and let the hospital treat that. The general rule for most all these cold injuries is do not rewarm unless you can be sure that you can keep that extremity warm for the duration of the treatment. So especially in the backcountry, if you have a long trip out, you don't want to rewarm out there and then refreeze on the way back out of the backcountry. Okay, so let's talk about some exposure to heat. If you are generating more heat or absorb more heat than what you lose, your body temperature will increase and you'll get hyperthermic. If you don't cool yourself off, this will eventually lead to death. So we distinguish between two general types here, heat cramps and heat exhaustion, and heat stroke. So heat cramps or heat exhaustion being the less serious version, and heat stroke the more serious. With heat cramps and heat exhaustion, the patient is still usually sweating and trying to cool themselves down, and so they're going to have skin that is moist and pale from that sweat. With heat stroke, they've exhausted all of their ability to sweat, and so their skin is generally going to be hot and dry. It may be slightly moist if they've just recently stopped sweating, though, and are on their way into heat stroke. So that'd be like a transitionary finding. So for heat exhaustion, some typical signs and symptoms. Patients will complain of muscle cramps, weakness or exhaustion. There'll be rapid, shallow breathing, weak pulse, perspiring heavily, possible loss of consciousness, but that should be like a syncopal episode, and they should be talking to you in general with heat exhaustion. For heat stroke, similar symptoms. Their pulse is going to be more likely a full rapid pulse, a generalized weakness, little or no perspiration, some variety of altered mental status, possible seizures. So the reason we need to distinguish between these two is because the treatment for these is a little different. So for both of them, you want to remove from the hot environment, obviously. For heat exhaustion, you should administer oxygen as necessary. If they're wearing heavy clothing, loosen or remove that. Lay them down, and they can have sips of water, and then go ahead and transport them. For heat stroke, typically their level of consciousness is going to be altered enough that it's not safe to give them anything by mouth, and we're going to want to try and actively cool them, so we're going to apply cool packs to their core. You can use wet cloths, you can fan them, you can do anything within reason to try and cool that patient down, but they need fairly rapid transport. So take a look at this case and see if you can figure out what this patient is showing signs and symptoms of. So he is still shivering, and he is conscious but confused. This would be early stages of hypothermia. So in this one, the skin is hot, moist, and flushed. This patient is probably heat exhaustion transitioning to heat stroke. This patient is a more advanced case of hypothermia now, since he is no longer shivering. So we'll talk about some water-related emergencies briefly. So a variety of activities take place in water, boating, water skiing, etc. And all these things can incur injuries and have accidents associated. Here in Moscow, our main water attraction is the Hamilton Low outdoor rec pool there. So drowning patients, they may or may not have water full in their lungs. In general, the water may or may not be there is not something that we directly deal with. So treatment here is rescue breathing and CPR if necessary. These patients are likely to have a pulse, so rescue breathing is what you're going to do. If you can get some air in there and get them breathing again on their own. They may vomit up the water on their own. These patients may need to have a little bit more forceful ventilation, but should be transported without delay. Diving accidents. This happens when people dive into shallower water and hit their head on the bottom. When they possibly break the neck doing that, they may lose the ability to control their own respirations and have some further paralysis beyond that. In general, where there's lifeguards available, we're going to be the care after the patient is out of the water and after the lifeguards have provided the initial assessment, initial packaging. Scuba diving accidents do occur, typically not in our response area. Some of these injuries can include arterial gas embolism, where they get nitrogen gas bubbles in their bloodstream. This can be due to inadequate training, can be due to them surfacing too quickly from a deep dive. It can take up to 48 hours to appear, so it may be that somebody has gone one of these trips on the coast and wound up back in our response area, complaining of these symptoms. If you encounter one of these patients, it's going to be a pretty rare event, and so there are these emergency numbers set up to help with assessment and treatment. Our local hospital, Gritman, does have a hyperbaric chamber to treat these, so we can transport there. For water rescue, in general, we're not going to be any kind of primary water rescue source, but should you find yourself out on your own or in an exceptional circumstance, these are the steps. So the best way to perform a water rescue is just to stay on the shore and reach the patient with your arm if they're close enough, with a branch or a pole. Most pools have large poles with hooks on the end of them just for this circumstance. That's the safest way to get somebody that is struggling or drowning, is to stay on the shore yourself, get a solid object and reach for them. Next best is to throw a rope or throw something that floats. So think of your throw bags for rafting, whitewater rescue. The reason that this isn't as preferable is that it takes some skill to throw the bag correctly, and it is a little harder for that person out there to grab and hold on to a rope that may or may not be floating towards them. But that is still relatively safe for the rescuer to throw an object or a rope. Next worst is to get in a boat and row out to the patient. The danger here is that the struggling, drowning victim grabs your boat and capsizes it and ends up dumping you in the water. If you can avoid that, if you have a large enough boat or raft, rowing to the patient is a good way to go. Finally, of last resort, swim to the patient yourself. Realize that this has caused deaths of numerous people trying to attempt to rescue somebody else, as the drowning person basically climbs on their rescuer's back and drowns them as well. So this is generally a bad idea to go and swim to the patient and attempt a rescue. For ice rescue, we do have some small ponds in our response area that people could fall through the ice into. Ice rescue training is beyond the scope of an EMT, but in general, the ideas are to, again, not go out there except as a last resort. So you can throw things, toss ropes with loops, go out in some kind of flat-bottomed boat, use a ladder perhaps to distribute the weight of the rescuer. These patients obviously are going to be hypothermic after being submerged in cold water, and they should always be transported. So here's a picture of somebody in a full ice rescue suit getting a rescue sled out to somebody that's fallen in the ice. Okay, we're going to switch to bites and stings now. So with spiders and insect bites, all spiders are poisonous. Most of them just don't have large enough fangs to actually pierce human skin, and or the poison isn't toxic enough to affect humans. There's only a few that are dangerous to people. Some people do have anaphylactic reactions to bites or stings, especially bee stings, hornets, wasps, those kind of things. And in that case, you want to remove that stinger quickly. To remove the stinger, you're going to use the flat edge of something like a credit card to scrape the stinger away. You want to avoid using tweezers because you can often have a little sac of venom attached to that stinger, and when you squeeze the stinger to try and remove it, you'll actually squeeze a little more venom into the wound. So in Moscow, Idaho, we don't have brown recluses or black widow spiders, but we do have hobo spiders. So that's what a hobo spider looks like. And those can affect humans. Those do have enough poison and long enough fangs. Snake bites. There are poisonous snakes in Lewiston, not so much in the Moscow area. In general, most snake bites are not typically life-threatening. If they occur in the backcountry where you can't get care for an extended period of time, obviously that's going to be more dangerous. But it is going to be not in a real fast-progressing emergency. So stay calm, let the patient stay calm, and as rest as possible. So the more their heart is beaten, pumping faster, the more the venom is going to move and transport through the body quicker. We don't try and suck out any venom. They used to sell kits with special syringes and stuff to try and suck out venom. That's no longer recommended practice. We don't do cuts to remove any venom either. Marine life poisoning, we're not on the coast, but just in case you find yourself working for an agency that is, there are many marine animals that have toxins on them. If you do end up getting stung or treating somebody that is stung, salt water is the best way to rinse the affected area. For other kinds of ingesting marine life, we're going to treat that like any other ingested poisoning, essentially. And that's the end.